Hi everyone. Good evening. I am Dr. John T. Johnson. I am a consultant endocrinologist at Marsleva Medicity Pala in Kottayam, Kerala. Good evening, and you are watching Dr. KK's MedTalks non-stop show. Welcome to MedTalks Live. It's conversations that matter, an educational initiative which is supported by Eli Lilly. We all know that obesity is a common problem, and now it is recognized as a chronic, relapsing, and multifactorial disease which affects nearly every organ system in our body. And in addition to its increased prevalence, we know that it increases significantly the risk for diabetes, cardiovascular disease, fatty liver disease, sleep disorders, and several cancers. While lifestyle modification remains the foundation of obesity management, we have new pharmacotherapies which have become available, and these have transformed the treatment landscape, offering scientifically validated options which would provide meaningful and sustained weight reduction. In today's discussion, we shall aim to help patients understand how the drug therapies for obesity work, who may benefit from these medications, are there any safety concerns which are related to them, the effectiveness and the importance of individualized treatment decisions. Now let's look at what are the key updates regarding obesity. France becomes the first European Union country to reimburse anti-obesity drugs, thereby improving the patient access to evidence-based obesity treatment. I hope such a situation comes in our country as well. RNA-based obesity therapies have gained momentum, with ARO-INHBE showing promising reductions in liver fat and visceral adiposity. Updated guidelines strengthens support for tirzepatide, citing superior weight loss efficacy among available pharmacotherapies. Even in the Indian market, we will hear shortly that tirzepatide have significantly changed the way in which we treat patients with obesity. GLP-1 therapies linked to lower obesity-related complication risk, with greater benefit observed in patients who achieve a weight loss in excess of more than 15%. GLP-1 receptor agonists may reduce asthma exacerbations, with a recent study reporting that up to 26% lower risk is seen in people who are using a GLP-1 receptor agonist. With this, we shall move to the main part of today, and let's see what the topic for today is. In today's session, we are going to see an important aspect related to obesity, and yes, that is related to the drug therapies which are available for obesity. And with that, it's my great privilege to introduce our guest for today, Dr. Nisha Bhavani. And I would consider it as a special privilege because ma'am is a teacher and a mentor for all of us junior colleagues in the field of endocrinology practicing in Kerala. She is a distinguished endocrinologist and academician with extensive expertise in pediatric and adult endocrine disorders. She has completed her MD and following the DNB in endocrinology with a fellowship in pediatric endocrine. And currently, she serves as professor of endocrinology at Amrita Institute of Medical Science, Kochi. She has contributed significantly to the field of obesity, diabetes, growth disorders, and metabolic endocrinology through clinical practice, teaching, and research. Her patient-centric approach and academic excellence have made her a respected voice in obesity and metabolic health management. We are delighted, ma'am, to have you with us today, and we shall take this opportunity to discuss the evolving role of drug therapies in the management of obesity. Welcome, ma'am.
Thank you, Dr. Jones, for the kind introduction, and thank you, organizers, for giving us this opportunity.
So, without wasting much time, we shall enter into the most awaited part of today. And I am privileged to ask a couple of questions to Dr. Nisha, and she will definitely enlighten us with her clinical expertise. Ma'am, the question number one would be, what are the currently approved medical treatments for obesity?
Yes, we'll start with that basic question. Actually, if you read the textbook, there are many drugs which are described to treat obesity. But if a patient comes in front of you and asks for a drug for obesity, there are only few which are available to us in India, what we can prescribe routinely. The main group of drug is called GLP-1 receptor analogs. And among them, three are approved for obesity, that is liraglutide, semaglutide, and tirzepatide. Tirzepatide is different from semaglutide and liraglutide in that it has got an additional mechanism of action other than being a GLP-1 receptor analog. It has got a GIP receptor agonist action also. So, tirzepatide is more effective than semaglutide and liraglutide in managing obesity. So, for managing obesity, tirzepatide is the most beneficial drug among the three. We will discuss about the various other benefits in the subsequent questions. And other drug which we can give, which is not very effective, but what we can give is called orlistat. Orlistat acts by inhibiting the absorption of fat from the food which we give, but it is more effective when you are taking a lot of fat. Indians, we eat more of carbohydrate rich food. So it may not work effectively in Indians. And moreover, since fat is not being absorbed, it will produce some oily stools, which is sort of socially disabling to the patient. So till year or two back, we only had orlistat as a mostly single drug to treat obesity. But after the launch of tirzepatide in India, we have the most effective drug tirzepatide, followed by semaglutide and liraglutide, which are also approved drugs which have been available in the last 1 year. Liraglutide, the dosage at which it causes weight loss is not available in India till now. We have only the dosage which is available to treat diabetes because most of these drugs can treat diabetes also, which requires only a smaller dosage. But to treat obesity, we require higher dosages, which is available, which at the time, for the time being in India, we have mainly tirzepatide and semaglutide as treatment of obesity.
Yeah, thank you, ma'am, for letting us know about the three commonly used medications. And 2026 and in fact 2025 have become a very happy place for endocrinologists to be in. And that is mainly because of the introduction of tirzepatide followed by semaglutide into the Indian market. Prior to that, like ma'am said, it was very difficult to treat people when they come with so much motivation to an endocrine OPD to lose their weight.
Yes, exactly.
The another question for you, ma'am, would be how does these weight loss medications work in the body?
Okay. So I think the most effective drug, as I said, is tirzepatide and semaglutide. Uh, so we will discuss mainly about these drugs because that is what we commonly prescribed after they have become available in India. So mainly it acts in the brain by suppressing your appetite. You see a lot of food in front of you, you just don't feel like eating. So you don't have to voluntarily cut down on your diet and all. If you take the medicine, you just don't feel like eating. There is something called as a hedonic eating. For example, you are going for a party, you are taking a biryani, and then after you are full after a biryani, but then the next counter is the dessert counter. You see an ice cream there. Even if you are full, you feel like taking that ice cream. All of us do that, but then, if you are taking these drugs, you just don't feel like taking that extra calorie. Once you attain that feeling of satiety, that fullness, very easily. So you don't have to put in lot of effort to control your diet. That is the main mechanism of action. The second mechanism of action is, so first of all, you eat very little, and whatever little portion you are eating, it will remain in the stomach for longer time than it usually does, because these drugs delay the gastric emptying. Normally when we eat something, it goes from the stomach to the intestine, and that takes place in a pre-specified time, but then that gastric emptying is delayed. So whatever little food you are taking will remain in the stomach for longer time. So you will feel full all the time. You don't feel like taking in more food. So these are the two main mechanisms by which these drugs produce weight loss. Then there are so many other mechanisms, the incretin effect, these drugs will produce a see, when you take food, it will release more of insulin from the pancreas, and this will cause the breakdown of the carbohydrate in the diet. And then the incretin effect, that is called the incretin effect. So though all those effects are there, and then it antagonizes the glucagon action. So lot of effects are there, but the main effect is that it decreases your appetite, improves your satiety, and makes you feel full. So you don't have to take an extra effort to cut down on your calories. You automatically cut down on your calories and feel full, and you will feel satisfied even with a little amount of food you eat. So that is the main mechanism of action. The other lesser known, lesser effective drug, as I said, orlistat, it inhibits the amount of, decreases the amount of fat being absorbed into the body, but that mainly is a very weak drug, doesn't have much effect. So we will mainly focus on these GLP-1 receptor agonists and the dual GLP-GIP receptor agonists, tirzepatide and semaglutide.
Okay, ma'am. Thank you. And that has made the discussion much easier because many people are still confused about how these medications actually work. Because we have a question asking about how are these obesity drugs different from the fat burners. So do they also work as only fat burning medications? Is another thing which commonly comes from the patient side when they visit us in the OPD.
No, actually, none of these, the so-called fat burners or over-the-counter preparations, are scientifically proven to be beneficial for treating obesity. These GLP receptor agonists and the dual GLP GIP receptor agonists, that is called the semaglutide and the tirzepatide group, they have been scientifically proven that they will reduce the weight, and parallel to that, they will produce lot of other benefits in terms of diabetes, heart disease, kidney disease, asthma, this liver disease, in all the other aspects where obesity has got a side effect. See, obesity is not a simple problem. It affects other parts of the body. It affects the heart, kidney, liver, brain, lungs. All the systems get affected if you have uncontrolled obesity. So obesity is a disease. So treating obesity with this tirzepatide and semaglutide will improve the improve all the organ functions. So far, it has been shown to improve most of the organs which are affected adversely by obesity. So once you treat the obesity, the adverse effects of obesity on other organs in the body will also get better. So the so-called fat burners or OTC, which can burn down a little fat, they are not scientifically proven to be beneficial in your overall health. But it is not the case with this semaglutide and tirzepatide, where it causes benefit other than obesity in all the other organs, diabetes, hypertension, cholesterol, all other organs and diseases which are the consequences of obesity are also taken care of when you treat the obesity with these drugs. So it can never compare with over the counter preparations or any shortcuts, the so called shortcuts to treat obesity.
Yes, ma'am. Thank you for sharing that very important point. And because we have so many people who come to the OPD just because they know that there is a medication which can be used to reduce weight, they have a so-called perceived obesity. They may not be actually obese when you look at the measurements, but they would say that they will feel comfortable if they lose a little bit more weight. So who are actually eligible for drug therapies with these semaglutide and tirzepatide?
Okay. So that's a very important question. As you said, Jones, we face many patients coming and asking for these obesity drugs for cosmetic purposes and all. They just want to look slim and all. But there are like approved indications for this starting these drugs. So obesity in the commonly we measure using a index called BMI, which is called body mass index. That is your weight in kilogram divided by height in meter square. That is called BMI or body mass index. So based on the BMI, we should decide whether they will benefit from these anti-obesity drugs. So the approved indication is a BMI more than 30 kg per meter square or a BMI more than 27 with any associated diseases like diabetes, hypertension, dyslipidemia, or the other complications of obesity. So, if obesity is there with any complication, a BMI of 27, and if no complications are there with just obesity, BMI of 30 is the cutoff where you start anti obesity drugs. But Indians have more problems with obesity than Western countries. So all these approved indications are given by the American agencies, European agencies, and all. But Indians and such develop the complications of obesity at a much lesser rate. So for Indians, we can even bring down the cutoff of BMI to 25 with complications and 27 without complications. We can even extend to that level because Indians develop for Indians the definition of obesity itself is lower. And then there is another category called normal weight obesity. According to BMI, your weight will be normal, you are in a normal BMI category. But then you will be obese. It is mainly because of the visceral obesity. Visceral obesity means what? All of us will have large tummy, huge tummy. So if you take go and choose a shirt, you will ask for a 40 size. Your shoulder will be 40, but your tummy will be 42 or 44 size. That is the typical Indian obesity. You will be narrow at your shoulder, but you will have a huge belly. So that is called abdominal obesity or visceral obesity, which is very dangerous. The fat inside the abdomen has got lot of bad chemicals which will make you predisposed to heart attacks and other diseases. So even in normal weight obesity, these drugs are being tried to reduce the side effects of normal weight obesity. But the approved indications are once you have a BMI more than 30 without complication and more than 27 with complications.
Yeah, thank you, ma'am. So these days, even we find younger people, 16, 17, they also come asking for whether these medications can be started. So is there any age cutoff above which only we should be using these?
Yeah, it is approved. Actually, these drugs are approved. FDA, foreign countries have approved it for use about 12 years of age. Even liraglutide and semaglutide are approved for about 12 years of age. Tirzepatide also is getting approved. In India, it is still approved above 18 years of age. We don't have, but then we have many adolescents in the 12 to 18 years age group where they have tried everything, but they are not working. So since it is US approved by foreign agencies, we can even use in children above 12 years of age, provided they fail a reasonable amount of lifestyle modification and they are not able to lose weight because childhood obesity predisposes them to future cardiovascular diseases. So we should, once you go beyond a point, it is very difficult to treat obesity. So liraglutide is the first drug which has been approved in children about 12 years. Now the other drugs are also approved. We have even studies of liraglutide in children between 6 and 12 years of age, which shows their beneficial effect without much adverse effects. So the age group is getting lower and lower to start these anti-obesity drugs. Provided there is no other, so in children when we are treating obesity, we should make sure that there is no other secondary cause for obesity. especially syndromic obesity. Some children will have genetic problems which make them obese. So we should catch them and try to characterize their obesity before you start them on these drugs like semaglutide or terzepatide, because some of the genetic causes of obesity have got specific treatment, some which is very difficult to to avail in India. It is not available in India, but still you have to have a thorough workup before you start a child on the common GLP-1 receptor analogs. In adult patients, mostly it is an exogenous obesity, but then in children we have to be double. We have to make sure that we are not treating a case of genetic obesity. Some genetic obesities respond to these terzepatide and all, but then some genetic obesities have specific treatment which we should not miss. That is one thing which we should always ensure before you start a child on the common anti-obesity medications.
Okay, ma'am. Thank you. So, always another concern from the patient's perspective would be whether these medications are safe and what are the common side effects associated with terzepatide and semaglutide. So, can you share your experience with us?
Okay. The approval agents, the agencies have approved all these drugs after so many trials, which have shown that the benefits are much more compared to the side effects. So it is an approved therapy for obesity. So you don't have to be concerned much about the side effects. But having said that, when you start a patient on the anti-obesity drugs, they should know what side effects they should expect. So the most common side effects are related to its mechanism of action. That is, you don't feel like eating anything, and whatever you eat is going to remain in your stomach for longer time. So the side effect is also related to that. You feel bloated all the time. You may feel bloated all the time. That is, you feel their stomach full all the time. And for some people, it becomes very worse that they start vomiting or they develop diarrhea, constipation. All those gastrointestinal side effects can occur. To prevent that, what we usually do is we start these drugs on a small dosage, on one-eighth of the dose. The most effective dose, we start at a lower dosage and gradually titrate the dose up higher. So if we do that, people will develop a tachyphylaxis to these side effects. So they don't get these side effects once you start very slow and build up very slowly. So that is what we usually do. For terzepatide, we start with the most effective dose is 15 mg once a week, but then we start with 2.5, gradually titrate it up to 5, 7.5, 10, like that. So once you do that, the probability of getting these side effects are very less. But despite doing that, some people develop these side effects. It depends on the sensitivity of the patient to these drugs. And if they develop these side effects, you can go down on the dose and then wait for them to tolerate the dose. And another thing which you should do to reduce the gastrointestinal side effect are to eat small meals in small frequent meals. Don't eat large portions. You don't feel like eating, but if you eat large portions, you'll feel more bloated. So small frequent meals with a high protein diet, don't take too much fiber because it is not digested, it remains in the stomach, you will feel nauseated. So small portion meals, high protein meals you take, you will be better off with your GI side effects. So that is the common side effect which usually occurs in our clinical practice. Other very rare side effects are described, like pancreatitis, some effect on the thyroid, some effect on the eyes, and all, which are all very quite rare. Those are serious side effects, but then they are very, very rare, extremely rare. So when before you start a patient on these drugs, we ask them whether they have any history of pancreatitis or whether they have any cancers in the thyroid or any eye problems and all, and you get a checkup of your eye done, especially when you are starting treatment in an obese diabetic patient, you get a eyes checkup done. So the thing is that you should take these medications only under the supervision of a qualified endocrinologist or a physician. We should not take it over the counter or from persons who are not you like not the government has approved doctors who can prescribe these medications, because these medications can have serious side effects even though rare. We should always be on the lookout for these. But then, if you are under the care of a qualified physician or an endocrinologist who can treat these conditions, the chance of getting these side effects are extremely rare, especially the serious side effects. The local GI side effects can be usually dealt with by managing the lifestyle. Another thing which can occur is when you lose weight, you lose your fat and you lose some amount of your muscle also. So, to maintain your muscle, you should maintain a healthy exercise. You should maintain a healthy lifestyle so that your muscles don't get broken down when you lose your fat. So that is something which is very important. So maintaining a good diet and exercise along with this medication is extremely important to manage the side effects and be under the guidance of a qualified endocrinologist.
Yeah, so thank you, ma'am, for telling us about diet and exercise, because that was, in fact, going to be my next question for you, whether these medications can be used as a replacement for diet and exercise for losing weight.
No, it's never a replacement. It should be along with diet and exercise. Diet and exercise is the key. But the thing is that you don't have to put in an additional effort to maintain a low calorie diet because you don't feel like eating much when you take this medication. But the food which you choose should be important. It should be a high protein, low carb, low fat diet and not very rich in fiber. So a high protein diet is what is very good. High protein usually we get in pulses. For vegetarians, it all the dals and pulses, legumes and all will have lot of proteins. And the for non-vegetarians, egg white, fish, chicken and all will have lot of proteins. So that protein-rich food is what you should take when you are on these medications. And if you are not able to meet your protein requirements from your normal diet, you can also think of supplementing, taking some protein supplements, because you will not be taking lot of calories from rice and chapatis and all. So you will have to take some extra proteins if you are not able to take it from your normal diet. And also because you are restricting your calories, you may get lesser amount of what is needed, the vitamins and minerals and all. So you may end up taking some vitamin D, vitamin B complex and all, if you are restricting your food to a great extent. So you have to periodically check that. Your doctor will tell you to check your vitamin D levels and all. So if it is low, you have to supplement that. And B complex and other normal vitamins and minerals which you get from normal food. If you are restricting your calories, there's a chance that you may become deficient in that. So you can take. But if you are choosing your food correctly with lot of proteins, veggies, and egg white and fish and chicken and all, there is no chance that you will get deficient in these minerals and vitamins. But diet is very important, and exercise, as I said, aerobic as well as anaerobic exercises, because to build up your muscles and maintain the muscle mass, a good exercise regimen is very important. And to maintain the weight loss which you get from these drugs, this diet and exercise plays a very important role. So you should be very particular on your diet and exercise which your doctor is going to tell you whenever they are starting you on these drugs.
Yeah, thank you, ma'am. So another question which frequently comes up is, how much weight can I lose? So many patients walk to the OPD and they want to make a adjustment between the money they are going to spend on a particular medication and how much in return they are going to get in terms of the weight loss expectation. So can you just let us know about how much can we expect?
Yeah. So this terzepatide is the most effective drug in terms of weight loss. So we can get even up to 20 percentage reduction in weight. For example, if you start off with a 100 kg weight, 20 percentage means 20 kg. So if you take terzepatide for like the highest dose of terzepatide is 15 mg once a week. So terzepatide 15 mg once a week can produce a weight loss up to 20 kg. So your 100 kg is going to become 80 kg. If you take semaglutide, you may get a slightly lesser weight loss of around 15 percentage, but the maximum weight loss is with terzepatide. So around 20 kg weight loss for a 100 kg patient is what we usually expect. And you will get it not immediately, over around 6 months time. So initially, as I said, to reduce the side effects, we'll start with 2.5 mg once a week, then gradually build up. So the weight loss effect will be seen even with the in the first month. You may lose 2 or 3 kgs. Next month you may lose around 5 kgs. So like that, when you reach the 15 mg dose in around 6 months time, so the 15 mg dose will be reached in around 6 to 9 months time. With that dose, you will lose up to 20 kg for a 100 kg patient. And but the benefit of that amount of weight loss on the other organs is what is more rewarding than the absolute numbers, because it is going to produce a beneficial effect on all the organs and all the metabolism in the body. So that is what we should expect. But some patients lose far more weight with even a lower dose. Even with 5 mg, 10 mg, they are going to lose some 15, 20 kg. So it depends on, there's an individualized response to these drugs. Not everyone will lose all the weight, and some patients will lose the weight easily. Some patients it will be very difficult. So it is sort of variable, but then on an average you are going to lose 15 to 20 percentage of your initial weight loss with the maximum dose. So that is what you should expect. So when patients come and ask how long to take, we will tell for like we should keep the money ready for at least a year. We will see the weight loss and then we will decide how to take it forward.
Yes, thank you, ma'am. Because again, we are going to ask that very important question: are these medications meant for short-term or long-term use?
Actually, it is meant for long term use, because obesity is not like it is a disease like diabetes and hypertension and cholesterol and all. If you take the diabetes drug today, your sugars will be controlled today. Tomorrow, you don't take, it will go up. It is just like that obesity. Today, you are taking the drug, you will get the effect. Tomorrow, if you stop the drug, the effect is going to wane off. Even the studies have shown that. That is, if you stop the drug, you will gradually regain your weight. So, for maintaining the weight, you should be maintaining on your medications. But then it depends on the side effect profile and the benefits which you are going to get. So, truly speaking, obesity is a chronic condition, it's a chronic disease. It is not something that it happens because you overeat and you don't exercise much and all in the first place. But not everyone who eats the same amount of food and you don't exercise develops the same weight. So there's a genetic predisposition to that. I eat one idli, I will gain 1 kg. Somebody else eats one idli, they will gain only half kg. Somebody else gains 2 kg, somebody else will gain 3 kg with the same amount of food. So that is genetically predisposed. So, if you are predisposed to develop obesity, even a slight increase in the intake will cause an increase in weight. So, what these drugs are going to do is it will reduce the weight, but your genetic predisposition is not going to change. So, once you stop the drug, your weight is gradually going to return depending on your genetic makeup. So, obesity is a chronic disease. It needs chronic treatment, and there is no major side effect which occurs if you keep the drug for long. The side effects usually the nausea, vomiting, diarrhea, and all will occur usually in the initial days. Once you become like acclimatized to that medication, usually you'll tolerate the medicines and you will not have much side effects. But the problem is the cost associated with it. But then probably in the years to come, now that semaglutide, once the patent has gone, the Indian companies have started making biosimilars. The cost have drastically reduced. Like that, precipitate also, when the cost comes down, probably it is going to become affordable, just like our diabetic drugs and hypertensive drugs. So it has to be taken lifelong. But for the patient, to if they want to know how much money they should keep as a reserve for this drug, we can tell them that you take it for a 6 months or an year and see, and then we will take it forward. But then we are probably going to continue it longer term, provided they don't develop any serious side effects.
Yes, ma'am. So thank you for discussing that important question, because I was about to ask you about is weight regain a problem after stopping these medication, and you have said that yes, we should expect that weight regain to happen.
Yes.
So the next question, ma'am, is do these medications also help to control diabetes and blood pressure in addition to losing weight?
Yes, of course. So that is what, because this is not treating obesity, will treat all the complications of obesity. It is proven that weight loss as low as around 10%. So for a 100 kg patient, if they lose 10 kg, it is going to have gross beneficial effect on all the other conditions associated with obesity, starting with diabetes, hypertension, cholesterol, fatty liver, then heart disease, kidney disease, this one. So recent evidence on asthma, or obstructive sleep apnea. So most of the complications associated with obesity becomes better when you are on these drugs, which are treating obesity. And these drugs, so when these drugs are approved for diabetes also. So it is not only for obesity, it is approved for diabetes also, especially if a diabetic or an obese patient has got a heart disease or a kidney disease. These drugs should be started for those patients who have already had a heart disease, because it is shown that they will reduce the risk of further heart attacks. They will reduce the risk of kidney disease. So if they have complication, if they are an obese patient with diabetes, with heart disease, with kidney disease, they should be on these drugs, which will reduce the further progression of all the complications of diabetes. So it is beneficial for most of the complications of diabetes. The only thing which has shown to worsen is the retinopathy associated with diabetes. But any drug which improves the sugars will are prone to worsen the retinopathy or the complication of the diabetes in the eye. So an eye checkup is a must before you start the patient on these anti-obesity drugs.
Yeah. Thank you, ma'am. So can these medications affect any hormones which are there in our body?
It can affect the hormones in a positive way. We all know that obese patient, especially it will obese patients have got lot of problems with the sexual hormones like testosterone and estradiol. Obese females have a high tendency for polycystic ovary syndrome, because when you're obese, you develop some small tiny cysts, likely cysts in the ovary, from which more of male hormones come. So and these male hormones will cause irregular menstrual period, lot of hair growth in the face like males and all. So that is called polycystic ovarian syndrome, which the main driver of which is obesity. So it is these drugs are not at approved for PCOS or polycystic ovarian syndrome. But once you treat the obesity, the estrogen levels and the testosterone levels are all going to come normal, better in females, and it is going to improve their period regularity, improve the increased facial hair and all. It will reduce the facial hair. It will improve their fertility chances. decrease the chance of developing pregnancy induced diabetes, hypertension, and all. So it actually improves the hormones in females. Even in males, grossly obese males have lot of sexual dysfunction like erectile dysfunction, loss of libido. All these things can be there because of low testosterone. Because when you are very obese, the chemicals from the fat will act on your brain and produce less of hormones, which will make you sexually active. So once you treat the obesity, all these hormone levels are will become better, and your sexual functions are going to become normal. So very rarely these hormones, and also thyroid. When you are obese, your thyroid hormones can become abnormal. So once you treat the obesity, your thyroid hormones can become normal. So it is going to benefit lot of hormones. Again, vitamin D is another hormone which is low in obesity, because this vitamin D gets stored in the fat rather than in the blood. So once your fat becomes low, the vitamin D deficiency is also going to improve. So the treating obesity is going to improve many of your hormones in your body. The only hormone which is going to which can increase, or which is bad, which can increase, is calcitonin. I mean, someone who is predisposed to get a cancer, a special type of cancer in the thyroid called medullary thyroid cancer, it can cause an increase in calcitonin or medullary cancer. So that is why we usually, in patients who are predisposed to develop such a special type of cancers in the thyroid, we usually avoid these drugs. Other than that, most of the hormones are going to improve once you treat your obesity, because obesity is something which can make your hormones go haywire. So treating obesity will improve most of this. Even though these drugs are not approved for these hormonal problems, it will be beneficial for most of these hormone problems.
Yeah, thank you, ma'am. So, when you decide to start the patients on these medications, are they suitable for elderly patients, and how frequently should we monitor these patients while on therapy? So, not focusing only on elderly, but can we use it in elderly, and what are the usual monitoring frequency?
So there is no age cutoff, like a higher age cutoff. We told the lower age cutoff is 12 years, but there is no higher age cutoff beyond which you can't give GLP-1. If they are obese with uncontrolled diabetes, with heart disease and kidney disease, they are of course candidates for these drugs. But the problem is mainly with their tolerance, because they may feel nauseated more, vomiting. All those side effects may be slightly more for them, and with weight loss, their muscle is going to get affected. So if they are not capable enough to do muscle strengthening exercises, take a high protein diet, and maintain their diet and exercise, we should be little careful on in giving them these drugs. So we should that is why only a qualified doctor can prescribe these medications to elderly patients, see whether they will develop any side effects. Or an already frail individual, which is called sarcopenia, that is, here they are losing, they don't have any muscle at all. You give this and produce further weight loss, they will lose all their muscles, they are going to fall down, they are going to get a fracture. They are not candidates for giving these medicines. So you choose your medicine, choose your patient carefully, individualized treatment. It is not for everyone. So you should choose the patient right. It will be beneficial even for a 90-year-old, a healthy 90-year-old. If you feel the benefit is will be much more than the side effects, you definitely give them. But only thing, we should be under the supervision of a qualified endocrinologist. And how frequently to monitor, because these are new drugs, and Indians are being exposed to these drugs for the first time. We will monitor them closely. We will start with a small dose, and every month we will try to increase the dose little by little. So initially every month we will see the patient, unless we reach a certain minimum dose, we will see the patient every month. and titrate the dose higher. Once they become stable on a fixed dose, we can see them every 3 to 6 months. We should monitor them for side effects. If they develop nausea, vomiting, we will come down on the dose. If they develop any other side effects, we are going to manage that. We are going to monitor the eye when they are on these medications. We are going to monitor their muscle strength. We are going to monitor their weight loss. Everything we have to monitor. So initially, a close monitoring every 1 to 2 months is needed. Later, every 3 months, we should monitor them. For that matter, anyone with diabetes, we'll be seeing them every 3 months, because it is a chronic disease. Any problem can come anytime. So at least every 3 months we should be seeing them, especially, and we should re-emphasize the role of diet, exercise, mineral and vitamin replacement, and continuing medications in every visit.
Yeah, thank you, ma'am. So we have only two more questions for you. So this question is about what factors would finally determine which drug is prescribed to your patient with obesity. So it will be looking at the weight gain you want to achieve. Will that be the major determinant when you choose between semaglutide or tirzepatide?
Yes, it depends on the weight loss which you require, because maximum effectiveness for weight loss is for tirzepatide. So if weight loss is your major target, definitely we will start tirzepatide because it is the most effective drug. You lose 20 to 25 percentage of your weight with the maximum dose. For diabetes and cardiovascular complications and all, semaglutide is okay. With this one, the benefit for cardiovascular and kidney disease and all are there with semaglutide. Semaglutide. So for such patients, we may start semaglutide. But if it is for weight loss, it is mainly tirzepatide. So one is the amount of weight loss you require. More obese the patient, we will prefer more of tirzepatide. If we are giving it mainly for diabetes and cardiac protection and all, we may choose semaglutide. And again, the financial status of the patient also, we will consider when we start, when we decide on which drug to start, tirzepatide versus semaglutide, because semaglutide has got Indian biosimilars. So till the time biosimilars come for tirzepatide, tirzepatide is slightly more expensive than semaglutide, but we have more experience with injectable tirzepatide rather than injectable semaglutide because that was launched initially. So it is an individualized decision. We will give the option to the patient. We will tell the advantages of both to the patient, and we will. It is a like decision which we take in discussion with the patient, depending on the indication for which we are giving, and depending on the financial status of the patient also.
Okay, ma'am. Thank you. And this is my last question for you. After seeing so many patients who come to our OPD with obesity, what is the biggest myth about medical treatment for obesity which you think people face?
I think most people have a guilt that obesity is because they ate more, they didn't do much exercise, and they feel that obesity is something which they can control on their own. But as I said, obesity is a disease. You can prevent obesity, of course. For a child, as soon as a child is born, we give them strict, like we don't introduce a sugary food to them. We don't give them bakery items. We don't give them junk food, and we all of us build that culture. Probably we will be able to prevent obesity. But once obesity sets in, it is very difficult to treat. Whatever said and done, a very strict diet and exercise can make you lose only 3 to 5 percentage of weight, and this is genetically predisposed. If you are predisposed to develop obesity, you will develop obesity even with the normal amount of food you are taking. But prevention you can always do. So that should be our motive. You should prevent obesity From day one, the child is born, the whole food culture of the society should change in a way to prevent obesity. But once obesity sets in, it has to be treated medically with lifestyle. Lifestyle alone is not enough to treat obesity. You may lose around 1 or 2 kg or 3 or maximum 5 kg for 100 kg, which is not enough to produce the benefits. So it most often it will require medicines. It is not medicalization of a normal condition. It is a disease which needs treatment. And we have effective drugs for treatment for obesity now, and we should make use of that opportunity and meet your doctor and discuss about these things whether you need medications or not. But not everyone is a candidate for these drugs. We should choose the patient right and individualized treatment, and these medications should be taken under the supervision of a qualified endocrinologist.
Yeah, so thank you, ma'am, for joining us at the end of a busy OPD day. And thank you, Dr. Nisha. That
Thank you,
will
Dr.
be, yeah, thank you, ma'am. So that will be all for today. And Dr. KK's Med Talks will return again with another exciting edition soon. Keep watching Dr. KK's Med Talks, and namaskar and thank you.
Thank you, Dr. Jones. Thank you, organizers.